Imagine a medical diagnosis that completely flips from totally healthy to severe condition simply because the patient chose a different brand of panty liner for their test.
Right, which sounds absurd, but it happens.
It really does.
Yeah.
Or, a scenario where doing some light housework instantly upgrades a really mild clinical issue into a catastrophic surgical candidate.
Yeah, the data on that is actually pretty shocking when you dig into it.
It is. So today, we're exploring the surprisingly murky, highly subjective world of evaluating stress urinary incontinence, or SUI. We're looking at the lengths medical science has to go to measure a problem that is inherently, really tough to pin down.
It's a fascinating clinical challenge, honestly, because when a patient presents with SUI, reporting leakage related to physical exertion, the clinical team has to establish a precise severity baseline.
Right, they need numbers.
Exactly. But relying on self-reporting in this space is notoriously unreliable. And it's not just because of the stigma, though that's huge, but because human perception of fluid volume is just inherently flawed.
Oh, absolutely. I mean, if someone asks you how much you ate at a party, and you say, oh, I just had a few handfuls of snacks, that is entirely subjective.
Yeah,
Like,
exactly.
your handful of snacks might be a few almonds, and mine might be a massive plate of nachos. It's the same with SUI. A patient's self-reported, I leak a little bit, could mean vastly different things.
It really could.
So our mission today is to unpack exactly what takes place during formal 1 hour and 24-hour pad weight tests. We're going to look at the mechanics, the physics of the testing materials, and how doctors transform a simple household object into a precise diagnostic tool.
Yeah, a standard kitchen scale, basically.
Right. Okay, let's unpack this. How do we actually move from subjective patient memory to hard, actionable data?
Well, the fastest route to objective data is the 1-hour pad test. This is typically conducted in a strictly controlled clinical environment.
So, like, right there in the doctor's office.
Yeah, usually right in the clinic.
Yeah.
The International Continence Society, or ICS, they established a highly specific protocol for this. The goal is to standardize the physical stresses that overcome the urethral sphincter.
Because clinical reproducibility is everything.
Exactly.
Yeah.
They need to know they can get the same baseline every time.
And when you dive into this ICS protocol, it is intensely specific. Like, imagine you're the one sitting there in the clinic. The doctor doesn't just hand you a bottle of water and say, let us know what happened.
No, not at all.
It is a highly choreographed physiological obstacle course.
It really is. So the baseline starts with a pre-weighed absorbent pad.
Yeah.
And I mean measured down to the 10th of a gram.
Wow. Okay. Very precise.
Yeah. And then we have to prime the system. Now, in standard protocols, the patient begins without voiding. But it's worth noting that for maximum standardization, some urodynamic variations of this test actually require a retrograde filling of the bladder via catheter.
Wait, a catheter?
Yeah, they fill it to about 50 to 75% of the functional bladder capacity.
Right, which, I mean, it makes perfect sense from a physics standpoint. Because if you want to measure the resistance of the urethral sphincter, you need a known, consistent pressure pushing against it.
Exactly, the detrusor pressure.
Yeah, you can't just hope the patient naturally drank enough water that morning and has a full bladder.
Precisely. You're setting up a known hydrostatic pressure gradient. But if they aren't using the catheterization method, which is common, the standard ICS oral fluid challenge comes into play.
Okay, what does that look like?
The patient is instructed to drink 500 milliliters of sodium-free liquid in under 15 minutes.
I want to pause on that detail for a second because the chemistry there is crucial. Why specifically sodium-free?
It's a great question.
Because if you introduce a sodium load, you alter the osmotic gradient in the loops of Henle. The body retains the water to maintain serum osmolality, which, it delays rapid diuresis.
Right, the kidneys hold on to the fluid.
Exactly. And since we only have a 60-minute window for this test, we need that fluid processing through the kidneys and filling the bladder immediately.
That's exactly the mechanism at work. You need a rapid, predictable increase in bladder volume. So after that 15-minute fluid load, the patient just rests for 15 minutes to allow the diuresis to peak.
Okay, so we're 30 minutes in.
Yep. Then the physical exertion phase begins. For the next 30 minutes, the patient walks, which specifically must include climbing one flight of stairs up and down.
Which sets the baseline for normal ambulatory stress.
Correct. But the final 15 minutes of the hour, that's dedicated to explicit provocative maneuvers.
The obstacle course.
Yes. The clinical team is actively trying to force a mechanical failure of the sphincter. And the sequence is incredibly rigid. It's standing up from a sitting position 10 times, coughing vigorously 10 times, running in place for 1 minute, and bending over to pick up an object from the floor 5 times.
Man, from a biomechanical perspective, you can see exactly what they're doing there. Every single one of those maneuvers forces a sharp, sudden spike in intra-abdominal pressure.
Right, that downward force.
Yeah, when that downward vector of pressure hits the bladder, if the pelvic floor musculature or the urethral hypermobility is compromised, the pressure just overcomes the sphincter resistance and you get leakage.
It's pure fluid dynamics.
It is, but then there is the final maneuver in the ICS protocol that really caught my eye.
Repeat hand washing.
Yes, washing hands in running water for 1 minute. I have to push back on this one.
Oh, go for it.
Because if we are explicitly testing the mechanical failure of the sphincter under physical load, like stress urinary incontinence, why are we doing a psychological trigger test? Are we trying to provoke a parasympathetic nervous system response?
It's a really great observation, and it highlights the complexity of what these clinics are actually dealing with. Pure SUI is straightforward mechanics, like we said.
Right.
But the reality is a massive percentage of these patients present with mixed urinary incontinence.
Oh, meaning they have both?
Exactly. They have mechanical stress failure, but they also have detrusor overactivity, which is urge incontinence.
Ah, okay, so the running water is a sensory trigger to differentiate the two.
Exactly. The sound and the tactile sensation of running water initiates a conditioned reflex arc in the parasympathetic nervous system. That causes an involuntary detrusor contraction.
That makes so much sense.
Yeah, by including this in the standardized 1-hour test, clinicians can pinpoint the exact mechanism of the leakage. If the pad stays completely dry during the jumping and the coughing, but suddenly gains weight during the hand washing.
The clinician instantly knows they're dealing with urge incontinence, not stress incontinence.
Right, and that completely changes the surgical or pharmacological intervention.
That is brilliant clinical design, actually. So the hour wraps up, the obstacle course is finished, and the pad goes straight onto the scale.
Yep, straight to the kitchen scale.
And since the specific gravity of urine is roughly 1.000 to 1.030, which is basically identical to water for these clinical purposes, we map 1 gram of weight gain directly to 1 milliliter of urine loss. So what's the diagnostic threshold we are looking for here?
The ICS guidelines set the margin of experimental error at less than 1 gram, though some more stringent clinical protocols push that threshold to 1.4 grams.
Okay.
Anything under that is considered clinically dry.
Because at that microscopic level, you could just be weighing normal vaginal discharge or like residual sweat from the patient running in place for a minute.
Precisely. You have to filter out the ambient moisture. But if the weight gain clears that 1 to 1.4 gram threshold, it's considered a positive test.
Okay, and how do they grade it from there?
From there, the severity stratification is rigid. So 1 to 10 grams is mild, 11 to 50 grams is moderate, and anything over 50 grams in that single hour is classified as severe.
Which, I mean, that is a profound volume of fluid when you think about it happening in a 60-minute window.
It really is.
But this brings up a glaring issue with the 1-hour test, right? Because it is a highly engineered, totally artificial snapshot.
Yeah, it's very sterile.
The patient is hyper-aware, they've been artificially loaded with half a liter of fluid in 15 minutes, and they are performing this highly concentrated sequence of Valsalva maneuvers that they might literally never do in their normal day-to-day life.
This raises an important question, though, which is the critical problem of ecological validity.
Right.
If a patient works a sedentary desk job, their functional reality doesn't involve doing 10 vigorous coughs followed immediately by running in place.
Exactly.
If we base surgical decisions purely on this artificial 1-hour stress test, we really risk overtreating or misdiagnosing the patient's functional impairment. We need data that reflects their actual everyday environment.
Which means we have to pivot to the 24-hour home pad test. If the 1-hour test is a photograph, the 24-hour test is like a documentary.
That's a great way to put it.
It accounts for natural variations in circadian hydration, fatigue of the pelvic floor muscles over a long day, and the reality of the patient's actual kinetic environment. But the logistics of this, I mean, it basically transforms the patient into a walking laboratory.
It's an enormous compliance burden. It really is. The protocol mandates that upon waking, the patient voids completely to establish a zero baseline.
Right, empty the tank.
Yeah. Then they apply a pre-weighed pad and proceed with their day. But simultaneously, they must maintain a meticulous voiding diary,
Oh boy.
logging every milliliter of fluid intake and categorizing every physical activity they do.
And the pad swapping protocol is intense. They must change the pad every 4 to 6 hours, or immediately upon feeling saturation. But they can't just discard it.
No, definitely not.
The instant that pad is removed, they have to seal it inside an airtight Ziplocked bag.
That airtight seal is non-negotiable. We are dealing with vapor pressure here. If a pad containing body temperature urine is exposed to ambient air, the fluid will begin to vaporize almost immediately.
Which ruins the data.
It totally destroys the integrity of the objective weight data.
And to combat that evaporation, the protocols usually mandate that these sealed bags be stored in the refrigerator until they are returned to the clinic.
Yeah, next to the milk and eggs.
I have to admit, the logistics here are staggering. I mean, imagine going about your workday, managing these airtight bags, or opening your fridge at home to grab dinner and working around a stack of your own used continence pads. It is the least appetizing meal prep ever.
It really is deeply intrusive. But here's where it gets really interesting. The objective data it yields is unparalleled for mapping real-world severity.
If they follow the rules.
Right. After the 24-hour cycle, the clinic weighs all the sealed bags, subtracts the aggregate dry weights, and they usually use a control pad from the exact same manufacturing batch to account for ambient humidity absorbed by the dry pads, and then calculates the total 24-hour deficit.
And the stratification here shifts, right? Because we are looking at a much longer temporal window.
Right. For the 24-hour test, 4 to 20 grams is mild, 21 to 74 grams is moderate, and anything exceeding 75 grams is categorized as severe incontinence.
But here is where the data gets incredibly thorny, though. We assume the 24-hour test is the gold standard because it captures reality.
Yeah, that's the assumption.
But when we look at the clinical literature, there is a massive confounding variable that can completely hijack the diagnosis, and that is the patient's physical activity level on that specific day.
It's the ultimate flaw in the just go about your normal daily routine instruction. The ICS tells patients to just live their lives, but human behavior isn't static.
Right. The post-prostatectomy research clearly illustrates this. There was a pivotal study examining men dealing with SUI following the surgical removal of the prostate.
Yeah, very common side effect.
Right. When the prostate is resected, the internal urethral sphincter is often compromised, which leaves the patient entirely dependent on the external rhabdosphincter. This makes their continence highly mechanically sensitive to dynamic movement.
Extremely sensitive.
So the researchers had these men undergo 3 separate 24-hour pad tests, quantifying their activity on a rigid 0 to 3 scale. 0 is sedentary, 1 is light housework, 2 is moderate exertion, and 3 is vigorous aerobic exercise.
The resulting data variance from that study is just staggering.
What did they find?
The researchers demonstrated that a mere 1-point escalation in physical activity, say, transitioning from just sitting at a desk to doing some light sweeping in the kitchen, precipitated an average pad weight spike of 118 grams in a 24-hour period.
Wait, really? Over 100 grams just from light sweeping?
Yeah, and a 2-point escalation. The spike hit 138 grams.
That completely shatters the severity stratification we just talked about.
It completely invalidates it.
Because if that patient takes the test on a sedentary Sunday, they might leak, say, 15 grams. The doctor looks at the chart and says, great news, you have mild incontinence, let's try some conservative physical therapy.
Right.
But if they take that exact same test on a Tuesday, where they happen to carry heavy groceries and walk the dog, they leak 153 grams. They're instantly pushed into the severe category, and the doctor is suddenly prepping them for a surgical sling or an artificial urinary sphincter.
Exactly. It reveals how fundamentally precarious it is to rely on cumulative pad weight without indexing it directly to metabolic equivalent tasks or specific activity metrics. This is why many leading urologists argue the standardized instructions are just deeply flawed.
It's the Hawthorne effect in action, isn't it?
Completely.
If you know you are wearing a pre-weighed pad and you know you have to put it in a Ziploc bag in your fridge, your psychology shifts. You subconsciously restrict your movements.
You don't want to leak.
Yeah. You avoid lifting heavy things or taking the stairs because you want to avoid the discomfort and, frankly, the embarrassment of a saturated pad. You artificially lower your own kinetic load, which creates a massive false negative on the test.
That subconscious behavioral modification is a huge hurdle. Patients self-limit to avoid the trauma of the leak. It's why some researchers now actually advocate for instructing patients to operate at their absolute maximum tolerable activity level during the 24-hour test, specifically to circumvent that subconscious restriction.
So we have the immense variable of human behavior, but as we move from the biological to the physical, the actual engineering of the testing materials introduces an entirely new vector for error.
Oh, the pads themselves.
Yes. If the 24-hour test relies heavily on what the patient does, it is equally at the mercy of the thermodynamic properties of the pad itself.
This is where we have to look at the pad not as a passive receptacle, but as an active chemical and physical environment interacting with the perineal microclimate.
And the multinational trial conducted by researchers in Sydney and London is the perfect lens for this.
Yeah, that study is brilliant.
They wanted to isolate the pad material as an independent variable, so they essentially engineered a synthetic human perineum.
Which is wild to think about.
It is. They calibrated an incubator to exactly 37 degrees Celsius with 5% CO2, and they integrated a distilled water vaporization tray to perfectly mimic perineal sweat and the ambient atmospheric moisture of the human body.
They systematically instilled highly precise microvolumes of normal saline into various commercial pads to simulate minor urine leakage, and then expose them to this artificial biome for 4 to 8 hours.
And the thermodynamic data they pulled out of this incubator is just mind-blowing. Let's look at the thin pads first, like your standard carefree panty liners.
Right.
When you instill a small fluid volume into a thin matrix, you are creating a massive surface area to volume ratio. Because the pad is thin and constantly exposed to that 37-degree ambient heat, it essentially acts like a drop of water on a hot sidewalk.
Yeah, the evaporation is incredible. Over an 8-hour window, those thin panty liners lost between 60 to 83% of the instilled fluid volume to pure evaporation.
Wait, 83%. So if I use a thin pad, I might get a false negative because the evidence literally evaporated.
Yes,
Yeah.
which is a diagnostic catastrophe. If you have a patient with genuine mild SUI leaking perhaps 5 or 6 grams over a workday, and they opt for a discrete thin panty liner to maintain their comfort during the test.
The ambient heat of their own body is vaporizing the evidence before they ever get the chance to seal it in the bag.
Precisely. You get a clinical false negative because the data literally evaporated into thin air. The clinician weighs the pad, sees a 0.8 gram differential, and charts the patient as continent, completely ignoring the active leakage.
Wow. You are failing to diagnose early-stage pathology purely because of the thermodynamics of the testing material.
Yep. But the inverse of this problem is equally, if not more, disruptive. When the researchers analyzed the larger high-capacity pads, like the Tannic Comfort series, they observed the exact opposite phenomenon.
Because we aren't just dealing with cotton anymore, are we?
No, not at all.
These high-capacity pads are engineered with super-absorbent polymer cores, specifically sodium polyacrylate. This chemistry is designed to rapidly cross-link with water molecules. But these polymers are so hydrophilic, they don't discriminate between liquid urine and atmospheric vapor.
Exactly. They act as a powerful desiccant. In the incubator trial, when the researchers introduced entirely dry, highly absorbent pads into that humid 37-degree microclimate, the pads began rapidly gaining weight.
Just from sitting there.
Just from sitting there. The osmotic pressure of the superabsorbent core was literally stripping moisture out of the humid air.
It's like leaving a dry sponge in a steamy bathroom while you take a hot shower. The sponge doesn't need to touch the actual running water to get heavy. It absorbs the ambient humidity in the room.
That's a perfect analogy.
So if a totally continent patient wears a thick, super-absorbent pad for 24 hours, their natural perineal sweat and the ambient humidity trapped by their clothing is going to be relentlessly absorbed by that polyacrylate core.
Which completely artificially inflates the pad weight. If a healthy person wears one of these pads and does an hour of cardiovascular exercise, the pad will absorb a highly significant volume of apocrine and acrine sweat.
Which means the clinician weighs the pad, sees a 15-gram increase, and misdiagnoses a perfectly healthy continent patient with mild stress urinary incontinence simply because they sweat during a workout.
It creates a massive false positive vector.
That is wild.
If we connect this to the bigger picture, this specific material phenomenon actually explains a historical anomaly in the urological literature.
Oh, really?
Yeah. Decades ago, epidemiological studies suggested that normal continent women lost an average of 5 to 7 grams of urine a day.
Okay.
But modern, highly controlled urodynamic studies have revised that number down to roughly 0.3 grams.
That's a huge difference.
It is. Those older studies were almost certainly capturing sweat and atmospheric condensation absorbed by the testing materials rather than actual urinary leakage.
It's astonishing how the basic physics of evaporation and condensation can fundamentally rewrite epidemiological data.
It really is.
So, when a clinician is holding a pad that has gained 10 grams, how do they mathematically separate the sweat and vaginal discharge from the actual urine? I mean, how do they know?
Well, there are a few strategies, but one of the most elegant is pharmacological. Clinicians will sometimes prescribe an oral course of phenazopyridine alongside the 24-hour test.
Oh, the azo dye, the stuff typically used as a urinary tract analgesic.
Precisely. Phenazopyridine is excreted almost entirely unchanged by the kidneys, and it has a profound, highly visible side effect. It dyes the urine a vivid, unmistakable orange.
Oh, that is so smart.
Right. By utilizing this compound during the testing window, clinicians can visually verify that the mass absorbed by the pad's polymer core is actually urine. If the pad gains 10 grams but remains entirely white or clear, they can confidently attribute that mass to sweat, condensation, or discharge, thereby rescuing the test from a false positive.
Outsmarting the thermodynamics of the pad with renal biochemistry. That is incredibly clever. It really highlights just how complex this diagnostic pathway truly is. We start with a patient reporting a highly subjective symptom like a loss of control during a cough or a sneeze, and to quantify that reality, medical science has to navigate this total minefield of variables.
It demands an extraordinary level of precision. To accurately map SUI, you must account for detrusor pressure, osmotic gradients, behavioral psychology, and the thermodynamic properties of polymer resins.
Whether that means catheterizing a patient to exactly 75% capacity and having them run an obstacle course of coughing and stair climbing in a sterile clinic.
Or relying on the immense fortitude of a patient to accurately index their metabolic activity, rapidly seal their pads in airtight containers to halt vapor pressure, and store them in their refrigerator for 24 hours.
It is a profound logistical and psychological burden. The mental toll of managing this highly visible, deeply stigmatized process while trying to maintain a normal daily routine is just immense.
It is.
But isolating that objective kinetic data, understanding the exact volume of failure under specific physical loads, is the only rigorous way to determine whether a patient requires targeted pelvic floor physiotherapy or if their anatomy dictates the need for complex surgical intervention.
It is the necessary bridge between a symptom and a cure. But, looking at these methodologies, we have to acknowledge how rudimentary they still are.
Yeah, the Ziploc bags.
Right. The reliance on Ziploc bags and kitchen scales feels entirely archaic when you consider the trajectory of modern diagnostic technology. As we push further into the integration of smart fabrics and continuous biometric monitoring, the 24-hour pad test as we know it is likely nearing obsolescence.
The hardware is going to catch up to the clinical need.
Undoubtedly. Imagine a near-term horizon where the testing material itself is the diagnostic instrument. A patient is prescribed a smart pad integrated with microscopic, flexible biosensors and piezoelectric threads.
Wow.
This material wouldn't just sequester fluid, it would perform continuous real-time chemical assays to instantly differentiate the biochemical signature of urine from that of apocrine sweat or normal discharge.
Completely neutralizing the false positive risk of the superabsorbent polymer problem we just talked about.
Exactly. And simultaneously, it's tracking volume and kinetic data. Imagine that pad transmitting encrypted, continuous telemetry directly to the clinician's dashboard. The physician could overlay the exact millisecond of a 10-gram fluid loss with the accelerometer data from the patient's smartphone.
So they instantly correlate the leakage with a specific kinetic event like lifting a heavy box or jogging up a flight of stairs.
Precisely.
That completely eliminates the Hawthorne effect. The patient doesn't have to carry a voiding diary. They don't have to worry about vapor pressure or Ziploc bags in the fridge. They just wear the biometric fabric and live their actual unedited life. It takes a process that is currently fraught with embarrassment and mechanical error and turns it into seamless, invisible, highly objective data collection.
It restores dignity to the diagnostic process, which, honestly, in the realm of continence care, is perhaps the most vital advancement of all.
So what does this all mean? It means we're moving toward a future where removing the shame, eliminating the guesswork, and relying on pure integrated science can finally solve the mechanics of the human body without putting the patient through an obstacle course. That is a phenomenal vision of where this is heading. Thank you all for joining us on this deep dive into the extraordinary lengths we go to measure what we cannot easily see. Until next time, keep exploring the systems that run our world, and we'll catch you on the next deep dive.